Hello and welcome to the CSF Author Interview Podcast for February. I'm Professor Peter Nash from the Griffith University, and today we're very fortunate to be joined by Dr Giovanni Orsolini. So welcome, Dr Orsolini, and thank you so much for giving up your time. Today we'll be reviewing the effects of tofacitinib on bone damage in both rheumatoid arthritis and psoriatic arthritis. And we're particularly interested in discussing the involvement of the JAK-STAT pathway in bone homeostasis. So welcome, and can you just tell us a little bit about yourself, your university, and your research, please?
Thank you. We in Verona. We are a rheumatology unit, and we have a long expertise on bone diseases and osteoporosis. And in the last year, we focused on osteoimmunology. So how is the other part of the rheumatic disease, how the inflammation interacts with bone, and especially our interest is how our advanced therapies affect not only inflammation but also bone. And this I think is a very hot topic, and with a lot to discover. So
we're very used to looking at erosions and bone remodeling and bone turnover, osteoclast, rank ligand, that system, but we're not used to seeing the JAK-STAT pathway involved in osteoimmunology. So could you just summarize a little for the audience the bone remodeling, osteoclastogenesis, bone formation, and the differences between rheumatoid and psoriatic arthritis, where we see this dynamic of erosion and bone formation in the same joint almost in PSA patients?
Okay. I will start with some general features. Talking about JAK-STAT in osteoimmunology, as you said, we are not used to that. It's still something. There is a lot to discover in that. So the more we have is some indirect effect, some preliminary data. What we know about osteoimmunology and bone erosions is that we have to separate RA and psoriatic. They're completely different diseases about the bone homeostasis. And if we think about RA, we have in front a disease with an excess of resorption and a blunted nail formation. On the other side, the PSA is there is erosion, but there is also uncontrolled nail formation, and this is particularly tricky because if we think about cytokines and pathway involved in the disease, for example, we have interleukin 17 that is involved in bone erosion, also in RA. In PSA, also is involved in inflammation. So the difficult part in the osteoimmunology is sometimes to understand how other different systems interact, and it's also a field that needs to be investigated more because there is something that is not clear yet.
Okay, so we're used to rank ligand, we're used to TNF, IL-6 and IL-17 being involved on the resorption side. Tell us a little bit about the Wnt pathway and how that might be involved, particularly and DKK, particularly on the psoriatic arthritis side.
So we know that the DKK1 is a master regulator of the bone homeostasis. It's one of the key inhibitor of the Wnt pathway that is constitutively activated, leading to bone formation. So what we know from data is that DKK1 is high in rheumatoid arthritis patient, and on the other side is low in those patients with PSA or ankylosing spondylitis. And what is interesting is to see what some of these some of the drugs we have for those diseases affect this system. And for example, we described that DKK1 lowers when we use TNF-alpha inhibitors in rheumatoid arthritis. And on the other side, psoriatic arthritis behave differently. TNF-alpha inhibitors do not affect DKK1, but anti-interleukin 17 does. So increasing the DKK1 in psoriatic arthritis patients. So yeah, we think that is a key mediator, but those data also from drugs are still, we need to know more about the exact.
It sounds like a DKK antagonist might be a useful treatment, at least prevent erosive damage in RA. I was also interested, and for those in the audience who on the CSF website, we have access to a beautiful slide deck of this paper, and there are lovely figures in your paper. One of them, I noticed that ACPA seems to play a role, and is that a direct effect of the antibody, or is it via its action on other cytokines?
The effect of ACPA has been long debated because there were some very interesting data about how ACPA could stimulate osteoclast directly, so without any other intermediate. But those data has been contested later. One of the things we know about ACPA patient is that patients that are healthy, that are not patients, actually, are healthy subjects, but with a positivity for ACPA, they already have damage in terms of microarchitecture of bone. So ACPA do also contribute a lot on the erosive burden and also on the systemic health on bone in RA patient. We also described a systemic bone loss in those patients with a higher quartile of ACPA positivity titer.
Very interesting. What about, we can't ignore the sclerostin pathway. Is that involved in erosion formation or the bone formation, hyperproliferation of PSA?
So actually, I've not developed a lot on sclerostin. I'm not sure about the data. Our experience were mainly on DKK1. So I'm not sure what's it's the role of sclerostin in PSA. Our study, when we studied with those drugs, we didn't have much data on sclerostin.
Should be interesting with rheumatology coming along as a potential therapy. And the same, I've always been taught that the osteocyte is the conductor of the orchestra, the bone formation, osteoblast, and the osteoclast resorbing. Any thoughts on the role of the osteocyte in these diseases, or is that another area that you haven't quite got to yet?
It's difficult. We are used to think that osteocytes were just observer and doing nothing. What we are learning very recently is the osteocyte plays a big role on producing a mediator that orchestrate osteoclast activity. The thing that it's very difficult to study osteocyte, and I'm not sure we are still there. We still know how the osteocyte can be affected and how act on this.
So a lot of fascinating work to do. The other thing in your paper very nicely then turns to innate immunity, and it looks at the gamma delta T cells and cytokines produced by them, particularly IL-17. We've had this fascination trying to work out why, if IL-23 is upstream to TNF and 17, why the P19-23 inhibitors were not successful in ankylosing spondylitis studies. Can you give us a feel for where IL-17 comes from if it's not the 23-17 pathway?
I cannot answer to that.
Oh, okay, sorry. It's a fascinating thing to think about. People talk about IL-36 and IL-38, these other cytokines, but there must be a very independent IL-17 producing pathway. I thought you might be able to.
We know that IL-17 is produced by a large variety of cells. So it's and not everything is mediated by the IL-23 pathways. So
Okay. Thank you very much. Let's now turn our attention to your paper a little bit more, thinking about the JAK-STAT mechanism in bone cells and the influence that the JAK inhibitors might have on interfering with that. Can you tell us a little bit about your studies and what you found?
So actually, my studies on JAK-STAT are still on the way. So what we've done in this paper is try to summarize what are the evidence on JAK-STAT pathway inhibition to affect bone in rheumatic disease. The fact is that data are quite scarce. We know that JAK inhibitors and tofacitinib, among them, could arrest erosion, bone progression, and this is particularly true for patients, for example, for rheumatoid arthritis that have a high activity and they have a lot of information on ACPA positivity. But what is fascinating of this is that we have studies that show that bone progression in the halt of bone progression in RA is independent with inflammation. So JAK inhibitors can stop bone progression unrelated by the control inflammation, and it is particularly intriguing because we think that the key regulator, the key effect might be the inflammation, and could be true. But let us think that there is different ways in which JAK-STAT pathway is involved in bone.
Keep going.
We have some we have some data, but are quite scattered about only the JAK-STAT pathway and bone. We know that that STAT3, for example, is involved in bone. A gain of function model give you an increased osteoclast number and reduced BMD. We also have there's also a study on the inhibitors STAT3 that showed reduced in rank ligand and the osteoclastogenesis. So we know that JAK-STAT is involved in bone. And the fact is that JAK-STAT pathway is used by the inflammation, but not all inflammation. So JAK inhibitors, and especially tofacitinib, that is less specific than other JAK inhibitors, could have a pleiotropic effect also on bone.
Okay, so is there any selectivity to it? You haven't had a chance to look at JAK3 versus pan-JAK, or because tofacitinib is a fairly pan-JAK inhibitor.
Yeah. So this could be a plus that is a pan-JAK inhibitors, but as we don't know the exact pathway that could lead to bone affection in those diseases. We cannot tell if a selective JAK could be more or less effective than a pan-JAK on bone.
So that might explain the efficacy of the JAK inhibitors in reducing radiological progression, not just sharp scores, but erosion scores and joint space narrowing scores.
Sure.
I always thought the joint space narrowing was related to loss rather than erosions. And in your paper, you talk about pannus. Does pannus damage cartilage by a pressure effect or because it releases cytokines that activate matrix metalloproteinases or other proteinases?
Yeah.
Is it known?
Probably is a more it's difficult to tell. Both the options are valid. Of course, there is an invasion damage, but then we know that cartilage that doesn't have nourishment. The cartilage stands on the bone and gives his nourishment by the microchannel from bones. So it's severely affected by the microenvironment that there is on bone and the cytokines and the mediator released by bone. So I believe that is more the effect of cytokine inflammation that. And metalloproteins, as you said.
Yeah, another very fascinating area of research. Hey, so thank you very much for your interest. Any take-home message from your studies? And just to finish with, we're used to seeing anti-resorptive drugs, denosumab and zoledronate, show some efficacy in rheumatoid in reducing erosion numbers, separate to treating inflammation.
Sure.
What's your comments?
Of course, we know that rank ligand is a key molecule for erosion also in array, but not only. And having an antibody that block this pathway, of course, is of great efficacy. I think that we can't say that we can use the denosumab or zoledronate with rheumatoid arthritis as indication, but what we can do is to pay more attention to bone disease and to osteoporosis and osteopenia and fractures in those patients. And so when we have the option to use those drugs, use the more efficacy one that could give us a plus also on the erosion side.
Okay, so where you're going to go next with your studies and take-home message from the work that you've done so far?
So my take-home message is, I think the key one is what I just said. So to pay more attention to bone health in those patients, because it's a key feature and it's something that could affect quality of life. And we have to be more used to look at that, to correct factors. And we need also to understand better, the message is also to understand better what are the non-wanted effects of these drugs. So just not look only inflammation, but also what are the other effects.
Well, it's an exciting time, and we thank you very much for your fascinating paper. Thank you again. This has been the CSF Author Interview podcast for February. If you'd like to know more about this paper and others uploaded to the CSF website this month, there are detailed slide sets available in the publication section. It's cytokinesignaling.com. Please subscribe to this podcast on iTunes or wherever you get your podcast from, and give us some feedback and let us know what you think. Thank you so much, Dr. Orsolini, for your very interesting work, and we look forward to future developments and understanding better the JAK-STAT pathway and its inhibition in osteoimmunology. So thank you so much.
Thank you. Thank you.